Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
It's my pleasure to introduce to you Dr. David Zuckerman, who's my guest today. Dr. Zuckerman and I have known each other for more than 3 decades and have become good friends. He really is a great guy and is so willing to share his knowledge and to empower other providers. Dr. Zuckerman is a true pioneer and visionary not only for podiatry but for all specialties. His work in advancing a formalized, minimally invasive cadaveric surgical course training at the Louisiana State School of Medicine and bringing ESWT to both podiatric, chiropractic, and orthopedic professions has helped many patients by this work. David is also very well known for his expertise in the development of laser technology and specifically his development of the Remy laser. Dr. Zuckerman has treated many professional athletes in the National Football League, the National Basketball Association, and the National Hockey League. He has served as the scientific chairman and on the board of trustees for the Academy of Ambulatory Foot and Ankle Surgery. He was in private practice for nearly 30 years and now is the CEO and founder of Zuckerman Future Technology. He's published numerous articles about ESWT, extracorporeal shockwave therapy, and laser technology. Dr. Zuckerman has trained over 700 podiatrists and orthopedic surgery specialists in the use of ESWT for both upper and lower extremity tendon pathology. David developed the Remy FX laser, which is the only 45-watt triple wave laser under 10 pounds. I hope you enjoy this great conversation with my friend and colleague, Dr. David Zuckerman. Good morning, Dr. David Zuckerman with me for today's show, and we're going to talk about lasers. It's been a while since we've chatted. How have you been doing?
I've been doing great. Been doing very well. I'm excited to talk to you. We should talk more often. I apologize.
Gary, say DC.
I'm going to shut my phone off. Somebody keeps calling me. I apologize here.
No worries. We'll just start it over fresh.
Okay.
I'm ready. All right. Good morning. With Dr. David Zuckerman. We're going to talk about lasers this morning. Thanks for joining us on the show today.
Yeah, I appreciate you inviting me. This is exciting.
Yeah, well, we haven't talked for a while. I miss our chats because it's always, usually it's during wine time and we'll have a sip of great Cabernet and next thing you know, an hour's passed by. But anyhow, so we're going to talk about lasers this morning. I've heard you had a little interest in that.
A little bit.
Yeah.
Just a little bit. I know you asked me to tell you how I got involved with this. It's an interesting story.
Mm-hmm.
About 20 years ago. And, I've always been involved in technology, ESWT, you with the endoscopic plantar fasciotomies. But the word exclusion is how this happened. I don't like to exclude people. And way back when the pinpoint laser came out, a colleague of mine calls me up. What do you think of the pinpoint? I knew nothing about lasers, etc. And I said, let me look into it. And I found out that they were putting one laser in one area and nobody else could participate, which really bothered me. I think anybody that has the proper training, the proper education and interest should have availability. So moving forward, I was involved with a device. It's a long story. A colleague of mine, unfortunately, he passed away, named Steve Goldstein. He had diabetic neuropathy. And the he calls me up and says to me, Dave, I'm a diabetic. I knew he was. He says, I have this machine. It was called a Synexus, which I believe today is called Neurogenics.
Yeah, well, no. Actually, I think Synexus and Neurogenics are two separate entities. We actually have both machines, but
okay. I actually introduced the Synexus to the United States. So, but there's a reason why I'm telling you. I was always interested in technology, and I didn't know where to begin with lasers. So I was working with a family. I knew what was his name? The developer of the whole technology. Sanyar was his name. He's from France. But anyway, so I'm working. I started with Synexus. I still remember cutting holes in the machine to get the proper ventilation. But I believed in the technology. I thought it was a great idea for diabetic neuropathy. So, and I was doing well with it. It was my first time ever selling equipment. My friend introduced me to it. Steve Goldstein told me it's great. I know you love technology. You'd be perfect to introduce this to podiatry. This was probably, I don't know, probably 2000, 2001. I don't remember. It was that long ago. So I was doing well, and the company was doing horrible. They were the Dixons from Georgia, Atlanta, Georgia.
Okay.
So they bring a consultant in, and he's in, and I'm never forget. I'm finished practicing. I go to this Italian restaurant. I'm drinking wine, and the consultant there, his name was Charles Vollweiler, and he says to me, he says, "What is going on here? You're selling these machines. You're enjoying it, getting great. The company's doing terrible." And I'm eating and drinking. I said, "I'll tell you what it is. They hate their customers. They hate their customers." And then I said to him, he says, "What do you mean?" I says, "Everything is always the customer's fault and not the manufacturer." I said, "But anyway, I'm more interested in lasers. What do you know about lasers?"
Mm-hmm.
And then he says to me, "Well, I'm the national director for sales director for LightCure, which is a laser company in Delaware." And his name was Charles Vollweiler. We're still friends to this day. And we've been partners in a company called Aspen at one time. He has a wealth of information about lasers. He introduced me to a world. And to the point where, and we'll get into wavelengths and things like that, is I just couldn't believe that one wavelength was the only wavelength that worked.
Right.
And then I moved through various, but that's how I got started. I went from LightCure, the K laser, which is now Sumis today. I worked for Diomed. You got to put your time in, but you have to have that heart, and goal. And it all started with exclusion. I didn't like the fact that Pinpoint put one laser in and for one doctor and nobody else could do it. So it interested me in saying there's got to be another way.
Right.
And that's got my interest.
So I think I purchased my Remy from you about 4 or 5 years ago.
Yeah. I remember it's a blur. It was before COVID. I remember talking to you in France, and right. I still can see it was raining. I'm outside. Yeah, there's been many changes with the Remy also.
Right. Yeah. No, we're going to get to that. I wanted to dig into the physiology and the physics of laser a little bit to just kind of lay down a foundation. So basically, everybody knows what laser stands for, and light amplification with stimulated emission of radiation. Right? Is that the
right? I had to go back and think about that. I don't even think about that anymore.
Yeah. So, but basically, it's my understanding that what makes the laser a little bit different than other forms of light is that it has this monochronicity where it's just one wavelength. And I understand you can change the wavelengths, and then it's a coherent wave versus a non-coherent wave. Can you kind of bring us up to speed on that?
Yeah, I'm going to talk more practical.
Okay. All right.
Today, we started out with one single wavelength.
Okay.
We've now up to 3 multiple wavelengths now. Now, is one wavelength better than the next wavelength? One thing about wavelengths, which are produced I don't think there's a perfect wavelength.
Okay.
At all.
Okay.
There's a lot of factors in it. We do know that we can go, it's all about getting the proper dosage into the tissues to turn on a photochemical reaction to produce ATPs. I mean, I can go through a long explanation, but you have to hit the right dosage. It's like an antibiotic. You need the right dosage to get the therapeutic effect. And for example, when we had 45 watt lasers with one single wavelength at 980, we could never go full power because there was too much heat.
Okay.
And what we've learned is that if you put multiple wavelengths, like my Remy FX has 3 wavelengths in it, I can go full power, 45 watts, with it being cool and adjustable, and very comfortable. And that's been a big advance in lasers. I do think when you and the reason why I'm pointing out wavelengths is that if you have a 980 wavelength, it's not a straight beam. It vacillates plus or minus 20 degrees or 20 units in each direction. At 1 minute, it could be 1,000, and it could be 960. So there's no perfect wavelength. There's a therapeutic window where we know it's all about absorption. You got to get energy. If you want to keep it simple, you want to get the energy at a cellular level. And to tell you how ineffective lasers are at penetration, I'll give you an analogy. And the numbers aren't important, but the discrepancy is if you put 10,000 joules of energy into the body, you only need 6 joules, and this has been documented, to turn on the photochemical or photobiomodulation effect of the cerebellum. 6 joules.
Okay.
We're putting in at least 10,000 joules.
Okay.
So it tells you how they deflect, they reflect, they bounce off. Everybody says to me, well, what's the penetration of your laser? And my answer is, I don't know. Nobody knows because it's a body is a body. You can have a thin steak, a medium steak, a thick steak, the density. But we do know you need to get the proper dosage or fluids. And I got to tell you, with the Remy, we have what's called the wow experience. I can get rid of the pain immediately because I go by I don't go by the time. I go by a clinical evaluation.
So let me interject there because I think that's really something. Now, I had to do a little homework, before I got on with you because I didn't want to appear as the dummy that I really am. But
yeah, right.
but it was interesting to me that there is a difference in tissue absorption of different wavelengths based on the vascularity of the and the water content, lots of things going on that, would make it more clinical, right? Because every dose of a medicine is not the perfect dose for everyone.
Exactly. That is so true. That is in a nutshell. And what I mean by clinical outcome is that it's real simple. I'll give you an example of plantar fasciitis. You press on typically in the plantar medial insertion, it hurts.
Right.
You treat the whole bottom of the foot with the Remy laser, the entire bottom of the foot. When are you done? And this is something I teach. You're done when and it's the treatment time's between 5 and 10 minutes. We don't know what it is, but when you repalpate and they get significant decreased pain, you've turned on that photochemical reaction. I like to use analogies. It's like jump starting a battery in a car. You need that right charge or energy to get the engine running. You need a certain amount of energy, a minimum, to turn on the photochemical reaction. And the first sign that it's on is decreased pain. It's not the time at all.
So one of the other things I picked up in my homework was that, they thought that pain, at least in the early literature regarding laser, and a lot of this was on low level intensity, but that it was all due to the amelioration of inflammation. So they in the early literature, it was, well, pain gets better because you've knocked down the inflammatory component. Right. But now they're looking at the fact that the laser seems to cause a relatively sustained depolarization of the nerve, which is going to decrease the nociception, right? I mean, if you think about it, and correct me if I'm wrong, but applying this treatment to the plantar fascia per se is unlikely to to definitively change that tissue in that shorter period of time, but yet it shuts down the pain very quickly.
Yes.
So there's obviously more components here than just inflammation.
Oh, I agree. I could give you a list of 10. I could put on a scientific PowerPoint of 100 slides, but I want to point out one thing is when we say the bottom of the foot, you're really following the nerve distribution. Lasers are very positively affected with nerves, positively affected. So for example, you just don't run the laser over the plantar fascia. You go all the way into the toes. You follow nerve distribution. That is so important. And I'll give you an analogy because we do full body with the laser, with the Remy, podiatrists, chiropractor, physical therapies, pain. So if you have supraspinosus tendonitis, and I'm going to talk about between tendonitis and tendinosis a little bit later, it's not just rubbing it over the argent insertion. You want to think of nerves. You've got to do the cervical nerve roots that innervate it. For example, I had Dupuytren's contracture in my hand. Okay. Right. I couldn't even open it up. I was prying it up. Now, I did have hands-on physical therapy with the laser. Okay. Which I think they're very important. And that's one thing, and I like to jump around. The laser is just not do the laser. And we've talked about that with neuropathy.
Right.
It's not like you just swat it over there. It's a team approach. You got to be serious with neuropathy. It's just not, I always say, if you're going to get involved in something, get involved in it. It's a team approach. But I want to go back to the Dupuytren's. You just don't run it over the area that hurts. I followed the medium nerve. Okay. And I go over it. I'll tell you one quick story. Many, many years ago, I got trained by some great people. Dr. Nelson Marcuna. He's an electrical engineer, and he became a chiropractor. And I only tell these stories because I want doctors. When I train each doctor individually and as many times because it's not a one and done. Right. It's not here's a laser, goodbye. It's not. It's as the more you understand it and the more experience you have, the better you are. But the laser is only as good as the clinician behind it and the proper diagnosis. Right. And there's much more than just increased vascularity, lymphatics. And I'll give you an example. I once had a patient. This is 2004, and I'm in the room. I'm learning. We're using a super pulse laser, which I could talk about, and I'm treating plantar fasciitis. And the patient said, "My second and third fingers are swollen." I look at them; they're swollen, and the doctor said to me, "Go figure out what's the matter with them." And they had this. They've done everything with her. They wanted to put the patient on Imurin. That's how bad. CAT scan. Everything's normal. So what did I do? I follow, like I was taught, the nerve root. So I go over the carpal tunnel. I see a thin scar, real thin. And I said to the woman, "You ever have surgery?" "Oh yeah, years ago. It's wonderful." But I'm not thinking just nerves. I'm thinking lymphatics. You got to think of the better you're in anatomy, the better you are. So as I treated the lymphatics, I watched the swelling go down. She had lymphatic damage post-surgery. Okay. I mean, we use the Remy laser for lymphedema of the post-mastectomy in the face. It's just not tendonitis. There's a lot of other areas that can use it. It's amazing for post-op swelling and healing. It's just a trauma. I always call it pain in the ass. If there's pain, inflammation, arthritis, or lack of mobility, you're going to get a positive effect. Now, I am not convinced. They talk about cellular repair. Right. And you'll understand this better than anybody, especially with the plantar fasciitis. Okay. There's a difference between plantar fasciitis and plantar fasciosis. Big difference. I don't think that a laser, my definition of plantar fasciosis, if you didn't do a biopsy, it's not 6 months. It's failure to respond to treatments that were geared to inflammation, steroid injections, lasers, physical therapy, stretching, whatever. If they're failing to respond to that and you didn't do a biopsy, I'm not convinced MRIs or ultrasounds are definitive. But if they're failed to respond to it at all when you have the right diagnosis, that's a true degeneration. Right. And you need, high energy ASWT, a fasciotomy. You need something to traumatize that tissue. Now,
well, you could draw the analogy with a diabetic foot ulceration. You're not going to get that ulcer to heal until you debride it and set up the environment for it. And
Absolutely.
I think you made a great point that, a lot of these things that we treat, whether it's an ulcer or a neuropathic condition, they're very complex situations, and there unfortunately is no one magic bullet. And
Nope.
and I think that I love the laser, and I think it's really a great tool, but we have to have other tools in our tool bag. And, and so
it's comprehensive.
Exactly. But the laser gives you something that, in conjunction with the other things, I think kickstarts it a little bit. And since we brought up plantar fasciopathy, we're very good now at staging and grading plantar fasciopathy with diagnostic ultrasound. So we can tell you, are we treating a mouse or are we trying to treat an elephant? And so with the farther down the line cases that have more degenerative properties or presentation, we try to avoid fasciotomy. And we're using a lot of regenerative things, peptides particularly now. We used a lot of amnio, and prior to that, PRP. But I think with the laser, if we do let's say we debride the fascia with microneedling and then infiltrate, let's say BPC 157, which I happen to kind of be in love with right now. It's my peptide of the year. But then you follow that up with ESWT, or you follow that up with the laser treatment. I think those are synergistic.
You've made a very good point, because, and this is from, we have over 700 Remy lasers out there. So the most exciting part for me is not the laser. I love the laser. I get an opportunity to talk to many podiatrists and other healthcare practitioners, and I go by feedback. I mean, you can have studies, but there's nothing wrong with levels of evidence of personal experience. It's important. It shouldn't be discarded.
Exactly.
Okay. So, the reason why, Steve, the reason I'm saying this is because lasers do stimulate the immune system, and they do stimulate stem cell production. When you combine it, which is what you just said, with your peptides or your PRP, the results appear to be, from the people that are using, better.
Mm-hmm. Yeah. And, when you're in academic medicine, you can afford to just have one treatment arm in your study. But when you're taking care of a patient, you have to get them back in the game as soon as you possibly can. So it's not just a knife fight. You're taking every weapon that you have to get this patient better as quickly as you can. So that's why I think you have to package these modalities together.
Yeah. And that goes, it's just not the clinical aspect. You have to have a modality. And that's why the Remy, I designed it, because I have this philosophy that if you want a laser, you can afford it. Mm-hmm. Okay. You can't spend $30,000, $40,000, $50,000 on a laser. I mean, we are in a business. We want to help patients. A laser should be effective, affordable to the patient, and the practice should, be able to make a profit. You got to turn the lights on, but and it's got to be multifunctional. I've made the laser. It's just not pain. We're getting excellent results with fungus, believe it or not. And I can go on with fungus forever. Fungus is I'm changing my mind. It's not, first of all, it's not 90% with a laser, and it's just not one modality. But we're doing things to get it close. You're always working to a goal to get better and better and better. Right. But lasers were never, ever, ever 90% effective. The treatment of fungus isn't 90% effective. And the beauty of the Remy is that it's also a surgical. You can use it for coagulation, incision, evaporation. We're using it for IPKs, which is another and we're not 100% sure why it works, but IPKs are what I call porokeratosis, plug sweat ducts. Right. I mean, we're getting resolution, and for the feedback is, it's interesting. We have the Remy in Puerto Rico and the islands where they see a lot more plug sweat ducts, and they just started using it same way as warts. I think it's an immunoresponse, decreased inflammation, and it may be some type of coagulation of the duct. We're not 100% sure. We don't do biopsies to follow it up, but we're getting pain, we're getting resolution or a dramatic improvement to where the patient don't have to be debrided or sal acid or in pain monthly. That's a significant, improvement in the patient's life.
Yeah, and porokeratosis can be very difficult to treat because many times they're right under the fifth met head, or they're under an area where you really don't want to cut them out. And
we still inject them I still inject them with 4% alcohol. It hurts like hell. It's painful, painful.
We could give them a tibial nerve block and they wouldn't feel anything. But
that's what I would do.
Yeah. So
that's exactly what I do.
Now, since we're talking about IPK, and it's okay to jump around. This is a fun chat, and so I don't really care about, I just want to get information and learn more about it. But since we're talking about IPKs, now, is that a different handpiece that connects to your laser, or is it?
Yes, I happen to have it here. And the thing about the Remy is you can take this off. I'm actually doing a video production after we're done, so I don't know if I have the handpieces in front of me. I do. Is you can go from fungus right to fungus.
Bring that handpiece down just a little bit so we can see it. Okay. Yeah. There we go.
I just went from the pain.
Yep.
I even have other ones. If you ever want to try them out, let me know. I'm sending it to you. This is a newer one. We've had a glass ball you can use. So we're always improving. The one thing, and I know you know this, you're always making it better and better and better. That's the whole game.
Right.
Don't be satisfied. And then you can go to... We used to have a bare fiber that you could clip it. You had to clip it. Let me put this down. And now we have this. This is the surgical attachment. Then I'm going to tell you about what we're working on. We're working on matrixectomies now, which we're almost finished.
Yeah.
I have a Dr. Clint Jones he's used. It's interesting when you meet people, just like I met you. You can always learn from somebody. Don't ever stop learning.
No.
We have matrixectomies, which will be coming out sure, but this is the surgical.
Okay.
Okay. And instead of a bare fiber, this is autoclavable.
Okay.
You just use it, put it in. This is a 3 millimeter spot size. The Remy is both surgical and non-surgical. So you got most lasers are just therapeutic. Wounds,
right.
Tendinopathies, but it's also surgical too.
So let's talk about that. So is it energy density and wavelength that change it from a surgical to a non-surgical laser?
So
thermal versus non-thermal?
Yeah. That's it in a nutshell, but it's the programs that you put into. We have specific programs that increase the power density and the handpieces, the spot size. The wavelengths are always the same.
Okay.
But it's the spot size. If you go into a 30 millimeter, you're dispersing the energy. Plus, you have different programs that are put in there. But if I were to take, for example, when we do pain, we do 25 watts continuously. When we're doing surgery, it's called average power. The average power is really the therapeutic. How you determine what's actually the type of energy. There's peak powers, there's average powers here. You're looking at a laser, it's average power that's coming out of the handpiece. So the average power here, because it's only 3 millimeters, is very focused. If I were to, it's interesting. You talk about lasers, class 4 lasers, burning people.
Right.
They can, if they're used, anything can burn anybody if it's used improperly. Like for example, if you actually put the wrong handpiece on and start treating pain, I don't know why you would do this. You burn a hole through the patient.
Right. Well, so you mentioned wavelength, right? Now, let's say for fungus versus an IPK, are you finding one wavelength is better than another wavelength? And then you said you combined 3 different wavelengths. So tell me about that.
No, the answer is no. What it's allowing me to do is getting, when we're talking about pain, it's getting the most. Remember, I told you lasers poorly penetrate here. We're not talking about the surgery, we're talking about the therapeutic.
Okay.
They're poorly absorbed.
All right.
Surgery, it's a cutting mode. It's thermal.
Right.
Okay. Well, the problem is that you need to get the correct amount of dosage at the target.
Okay.
Which is deep-seated, what they call deep-seated pathology. So when you add wavelengths to it, we're able to, and they all work together. It's not, you can do, but interesting with the Remy is it's not, you can put all the wavelengths are working together. You can do them individually, or you can combine them. We combine them. And I have found they're much cooler, so I can pump more energy in. Like our treatment times are under 5 minutes now.
For an IPK or?
Well, no, I'm talking about for therapy, for plantar fasciitis.
Oh, okay.
5 minutes or
All right.
less.
Now, what about an IPK? Is there?
It's a clinical appearance of the changes in the skin.
Okay.
It's
Just
same
like
thing
you
with
would
warts.
like you would when you apply phenol, you look for that grayish coloration of the.
That's a perfect analogy, and I have videos of it showing. I don't have them available to put them on here, but it's when you're doing. It's interesting. We've actually developed even more with the poros and the verruca, because before we would, and there's nothing, you would contact, it would turn black, brown, and a little bit of white. That's the clinical endpoint. It takes about less than 30 seconds to develop that. But in some people, it was uncomfortable or painful because we use no anesthetic. Now we have it where you don't even touch it, and you can see the erythema and the purple like you would in a flash lamp pulse dye laser. So you can. We're doing we've done it in 6-year-olds. The Remy in hands and feet. The Remy it's in Europe also. So in Europe, podiatrists treat the hands and the feet. It's a very different, whole different system there. In Ohio also, you treat the hands and the feet, and they're doing infants. With this infants. So it's the technique's getting better and better. We probably have, oh God, there's hundreds. I wish I could put it together. Have a study. I can do retrospective studies, but to have a study done where you have a control or another product, that's you can't do that unless you're an academic. And I was thinking the other day, I'm going to start going to some of the academic institutions, because the Temple School of Podiatry is 10 minutes from me, and offering them, hey, let's do a study.
Right. No, I think that'd be very good. Now let's go back to, if let's say we're treating an IPK, is that usually a one treatment and you're done, or is it usually a series? You got to treat it.
I'll tell you exactly. I always say that it's anywhere between 1 and 10 treatments, because you don't want you don't want to ever pin down the wrong number, but the average is anywhere from 1 to 3.
Okay.
Because you don't know, especially with warts, you don't know. And we're getting very resistant warts. They're all over the bottom of the foot that are going away in less than 5 treatments without a needle. Patients hate needles.
Yeah, they do, unless you're very good with your injection technique, which I've always tried to emphasize and teach. But no, this is a big advance, because if you're able to take an IPK and have a patient come in for 1 to 3, maybe 5 treatments, and it's gone, that's a big deal. You haven't taken them out of their day to day with an incision. Yeah, so there's a big advantage to that, even though insurance may not cover it. People value
it's interesting. They do cover the wart, not the eye. I don't believe they cover the poor keratotic treatment, but warts they do cover it. It's just a different modality that you're using. And I did that. I wanted. It's not covered. The pain is not covered. The the fungus toenails not covered, but the wart is covered. So I actually, you got to think a little. You can't think all scientific. I actually brought warts in originally to figure out. So they have multiple. You need a multifunction laser, and the fact that it is insurance covered helps the doctor afford it more. Right. Because I want a doctor to be successful. It's interesting. I've talked to some doctors. Oh, I have XYZ laser. I love it. That's great. And then I ask them, well, you making any money? I don't know.
Right.
Unfortunately, we're in that world. Obviously, the patient comes first, but and the way I know the Remy is very successful, I have doctors buying 5, 10 more of them.
This episode is sponsored by Zuckerman Future Technologies. Their Remy laser is a Class 4 laser for professionals. It is different from anything available on the market in that it is a lightweight, 4 pounds, and compact but powerful device. Its large touchscreen makes it easy to use, and it has multiple wavelengths of 650, 810, and 980 nanometers, power variables up to 30 watts, and a safety rating that make it optimal for many conditions. With the Remy laser, you can give your patients effective, pain-free treatment of soft tissue issues. It is ideal for treating plantar fasciitis, fasciopathy, Achilles tendinopathy, peripheral neuropathy, neuromas, arthritis, onychomycosis, warts, and more. It is the only laser with FDA 510(k) approval and insurance coverage. Zuckerman Future Technology deals with all aspects of the Remy in-house, and this keeps out the middleman, which allows them to offer this revolutionary device at a 40% reduced price compared to anything that can provide the similar results. There are currently over 700 Remy lasers being used in the USA and Europe, and those numbers are rising every day. Learn more about this fantastic product and join the growing number of professionals who are benefiting from having the Remy in their practice. I personally implemented the Remy into my practice about 4 years ago, and I cannot say enough about the utility, versatility, and efficacy that I have seen with this technology. I can also say that of all the capital equipment that I have purchased, and it has been a lot over the last 36 years, this is one of the best expenditures I have made. Zuckerman Future Technologies is offering the listeners of the Pod of Inquiry a really great deal. You'll get a $1,000 cart for the Remy laser when you use code 007. That's right, a $1,000 cart for the Remy laser, just for bona fide Pod of Inquiry spelunkers. You can go to the website, remylaser.com, plug in your James Bond code of 007, and get your free cart with a purchase of the Remy.
Well, yeah. I think, what you've done with your laser is really spectacular. Now, I have a very focused, limited practice, but I find multiple uses for it. And I would think that in a general podiatry practice, this would be the ideal laser because there's so many different things that you can treat with it. I'll tell you one thing that I found really good is in like post-operative wounds. And you'll always get a little bit of suture.
You taught me that.
Yeah. And we hit those with the Remy, and it's fantastic because it only takes a couple of minutes. And most of the time, I don't even have to put them on an antibiotic and then if I don't have to put them on an antibiotic and it takes just a couple of minutes to do, that's very easy to implement into your day-to-day clinical practice. And it's a benefit for the patient because now you're not messing up their gut microbiome by putting them on an antibiotic that they probably.
I remember your observation of that years ago. I listen to what everybody says. It's not like I may not respond, but I remember you telling me that. I teach that and say, Dr. Barrett, you should use it immediately. And it's interesting you talk about pain. There's studies where they're doing right in the operating room or in the office, right after the surgery. Veterinary medicine does this as well. If they have a laser, they laser every incision because decreased inflammation, swelling, better healing wound, better scarring. As you said, less chance of infection because lasers are antibacterial. I don't know if they're cidal or not. I think it's cidal, bactericidal.
Yeah, I think. There's also the component too that the laser's been shown to upregulate fibroblast production, and so it's a little bit counterintuitive. You would think that if you would upregulate fibroblasts that you would have more scar tissue, but that doesn't happen. And we've seen that with there's a peptide called thymosin beta 4, which I'm a big fan of. In any revision nerve surgery, we put thymosin beta 4 in post-operatively from the day of surgery to about the 8th day. And it decreases the scar tissue formation and it accelerates the wound healing. The wound heals faster, but it's hard to put those two things together because if you think that you're going to upregulate the fibroblast, you would think you would end up with more scar, but it doesn't. It actually ends up with less scar. So when you upregulate that fibroblast, something must be happening, and it's way above my biochemical understanding, but it just makes a better wound. So not only are we treating this suture, erythema, cellulitis, whatever you want to call it, but you're probably actually improving the wound from that fibroblastic activity, as well as you're
Well, it may move it quicker through the inflammatory phase of wound healing.
Right. And
because it's not excessive.
There's definitely a component, and I've seen with your laser where, and I think you asked me one day about common perineal, and I can take somebody that has a motor deficit of their EHL, and they, maybe 1 or 2 grades of motor strength lower, and I can do a treatment over the common perineal nerve, and that will increase the vascularity there, and they'll get normal motor strength. And we've demonstrated this. I think I've talked to you about the Phoenix.
I saw the video. It was published.
Yeah. And
with you injecting the common perineal under diagnostic ultrasound, and we saw the patient's motor function come back.
Right. And we've seen the same thing with the laser. And you would think, well, that's a pretty strong indication that there's definitely a lot of biological processes going on.
Yes.
Because you wouldn't see that if there was not an increase in vascularity. So
I agree. I mean, the foundation is the myelin sheath. This is it's much more than this. The myelin sheath is damaged in neuropathy. I think it's much more than that. And you get increased blood supply to the myelin sheath, and it repairs, the nerve insulation, and you get improvement with neuropathy. I want to tell you an interesting cases, and I just do not. First of all, I don't claim to be an expert in neuropathy. I don't. And I tell doctors this: if you're going to do this, you need to really know. It's a field.
Right.
Neuropathy is a field. Okay. So I had this patient that he had alcoholic neuropathy. Okay.
Right.
And he consulted with me, and I showed him he's getting really doing well. And he says, "Do you think?" And I want your opinion. That's why I'm bringing this up. The pain's much better. He had burning, stinging. First of all, I think neuropathy I call it a disease. I don't think you can cure it. I think you can improve the symptoms. I think you need continual treatment. It's not, here's a session of lasers or here's this. Do you think you can cure it? I'm asking, that's the first thing. I'm going to interview you. Do you think you can cure it?
Well, I think, first you have to preface everything by neuropathy is such a general term.
Yeah. Diabetic neuropathy.
Yeah. Diabetic peripheral neuropathy. No, I think we can make it much better. I think if you look at the pharmacology, interventions, gabapentin, pregabalin, duloxetine, they don't cure it. They help the patient manage it from a pain standpoint.
It's for symptomatology. It's not like the laser is therapeutic.
Right. So I guess the answer is if you can make the symptoms better or gone, the disease is still there.
Right. And that's so important. That's why you need endocrinologists. You need you need an internist involved. It's just not wave the laser, but the most important thing is figure out what the cause is.
Right.
Don't just look at the foot, look at the nerves, look at the whole body.
Oh, you're barking up my tree right now, because
I know.
When we first started with peripheral nerve decompression surgery in the early 2000s, we thought, wow, we've got this tremendous hammer and everything was a nail. And then we would see these patients, and the more you do peripheral nerve, the more humble you get, because there's just it's just super complex and there's lots of things going on. But we learned very quickly that you have to look at this patient from a whole standpoint, right? Do they have Lyme disease? Are they filled with mold? What's their thyroid situation? You can't just, unfortunately, almost all of medicine now is oriented to one symptom, one drug, one surgery, or one orthopedic condition, 1 or 2 different surgeries to address that. And that just doesn't seem to do much,
I'll tell you an interesting thing, Steve, is somebody once said, if I ever had to go back through my training, what's the one thing I would want to learn more? Is it doing more bunions? Is it doing more surgery? Is it doing, I don't know, whatever? It's not that. It's more medicine.
Yep.
You can't get enough of learning medicine.
That's exactly right. And that's what's happened to us. is that we were forced into this corner by these very complex cases that with the initial tools that we had, we were making a lot of people very much better, but some not better at all. And then, as you spend more time in this neuropathic arena, you start looking at these things. Well, if this patient's really sick, how is it that I'm going to do something peripherally and decompress them if they're an inflammatory nightmare?
Right.
So you have to, and people will say, well, you need to send them to endocrinology or you need to send them to, internal medicine. But the problem is that they will go and a lot of times they just get blown off. I mean, how many times do you see, people are in absolute love with the hemoglobin A1C, but they're not looking at how much insulin that poor person's having to pour out on a daily basis. And so their neuropathy, even though, like, let's say they have an A1C of 5.8, which a lot of the diabetics would, they would scream to have that kind of a level of A1C, but they're pumping out tremendous amounts of insulin. And so when you run a serum fasting insulin the same day that you run a serum fasting glucose, you can see their insulin is, ideally you want to be below 5. And some of these folks are 35, 40. So they're hyperinsulinemic, which is causing their neuroinflammation. So we're not going to get them better unless we get them on, carb restricted diets and that type of thing.
Absolutely.
Yeah.
A dietitian is just as important as a physician.
Oh, absolutely. And most physicians have no either interest or knowledge in nutrition.
Right.
Yeah.
I will tell you one thing that's it's beautiful is that because I or even using the lasers, I have medical doctors that treat depression, and they're they want my 3-wave Remy FX because they like that 1064.
Okay.
For some reason, they like that wavelength better. But there's research and clinical research showing, that treating we know for post-traumatic stress disorder, there are studies out there, and I was involved in clinics where they're treating because it's inflammation in the brain. But we don't understand depression. We don't really understand what we do a lot more than when I first was in practice, the role of inflammation in disease, in chronic disease. Right. And my dream has always been, and I'm slowly moving in this direction, is plantar fasciitis, post-operative wounds. But if you have colitis, pericarditis, where you don't, right now they are putting fibers down, therapeutic fibers and treating the colon, reduce inflammation to avoid surgery, because colitis is we have medications. I'm not saying there's anything wrong with them, but we're depressing the immune system. If you could treat it locally with lasers, non-invasive, okay, wow. To me, that would be the dream. That's always been my dream. And I've been involved with people that were working towards that. They're talking about COVID and they're actually using lasers. There's no really great studies because it's inflammation in the lungs where they're actually removing the inflammation in the lungs to reduce the serious side effects. So there's a lot more that can be done.
Now, you mentioned that 1064. So I came across a study a while back, and I haven't looked at it for a long period of time. But I think it was 1064 nanometer wavelength that they were using, and they were actually putting it on the prefrontal cortex. And then they found that if they administered concomitantly methylene blue, that they actually were able to stimulate and increase the mitochondrial energy activity, and they then saw that if they did that, it would go back and upregulate the hippocampus, which is critical in short-term memory, and that's usually one of the first brain structures affected by Alzheimer's disease. And so they were looking at it like that. Now, it's hard for me to imagine that a wavelength is getting through the cranium.
I know.
Is that possible?
Well, that's a good point. I'm going to go back and tell you a little story. When I was first working with lasers for fungus toenails. I believe I helped develop using the 980. The 1064 was the mainstay, because that's what started. The pinpoint was 1064. So we had a high speed camera, and I wanted to see if it would absorb into the nail bed.
Okay.
The laser, because it's all about dosage and absorbance. I knew that it was not the heat 20 years ago. It's a photobiomodulation. It's a photochemical reaction. See, I like to look at fungus toenails like wounds. Okay.
Right.
You need to repair it. So anyway, I wanted to check the penetration. We get this high-speed camera, and I'm watching the laser go through. I'll get to why I'm telling you this. I'm watching it go through. It went right through the bone and everything.
Okay.
But I didn't know what the dosage was when it hit the top of the nail and to the bottom. I didn't know how much energy was dissipated. I just saw the wavelength go through.
Okay.
So I know it does go through, but we don't know the energy level. It does go through bone.
Interesting.
Well, we don't know you understand what I'm saying? You have a wall, the dosage on one side of the wall. What's the dosage? Because it's all about dosage to get the therapeutic effect. What's it on the other side of the wall?
Right.
I don't know.
Right.
Fortunately, fungus is in the nail bed, which is great.
Yeah, but I think that makes the point that there certainly is a possibility to drive photons through the cranium. I mean,
they're doing it. There are studies out there doing it, and they're getting clinical, good clinical results. I mean, I talked to there's 3 or 4 medical doctors that found my laser, just the fact that it was 3 wavelengths, and I mean, it opened a whole new world up to me. And they start showing me this literature, the laser therapy in the brain. I mean, it's out there. It's not my field. Again, you should focus on something, be really good at what you focus on. Neuropathy, I don't consider myself an expert in neuropathy at all. I consider you an expert in it.
Well, the more I learn, the more I know that I don't know. So, it's complex. Anybody that tells you that they are like a super expert in neuropathy, you might want to run, because
I use the word "you're full of shit."
yeah, because it's so complex, like we talked about, and it's so multifactorial.
It's exciting, though. It doesn't give you your blood, and when you see some results, and like, wow, you changed somebody's life, and then all of a sudden you do the same thing and it's not working. Why isn't it working?
Right. Well, and
that's an opportunity.
Exactly. And that's what, at this stage in our careers, that's really the driver for me, is to try to develop different protocols, look at things a little bit more, from a whole person perspective, what's going on, these types of things, so.
I do want to make one comment that amazes me, because I get the education and the training of today's podiatrist is like, I'm so proud. I mean,
oh yeah,
it's just amazing to train these 3 and 4 year surgical residencies, these fellowships. The education is, I'm so impressed. I could get into the negative part with their debt, which is a whole nother story.
Right.
Which
we might have to
bring up, but
we might have to have another podcast just talking about, how difficult it is, and the debt structure of somebody that has to go through the training. And
a lot of people would be fired if I was in charge. That's all I can tell you. Well, I couldn't do that to my profession.
Nah, and everybody, there's a lot of negative comments about the profession. I actually think it's the greatest profession because it has so much latitude. It has a level of expertise that there's really no other.
It's a great profession. I'll tell you something that just blew my. The other day, I'm training a podiatrist. She's from Cleveland. I don't know if she'd want me to mention her name. So we're talking. I like to learn their background, how they became a podiatrist. And she tells me, she says, I want to hear the physics. And she, I tell her a little bit. I said, well, what's your background? I used to be a nuclear physicist.
You're right.
I mean, you'd be surprised the backgrounds of some of these podiatrists. It's amazing. I mean, I talked to another one this morning, and he's electrical engineering.
Right. No,
wow.
Yeah. Well, I mean, it's and it comes down to too is how much passion do you have? Right. You can be incredibly gifted intellectually, but if you don't have the passion and the love, then that's not going to get translated. So
I agree.
Yeah. So tell me about your new Remy, because I want to know about that. And, I think I bought what version did I buy? First or second?
It's here's the differences.
Okay.
And we're talking about I have two Remys. I have the Remy 30-watt dual, which is the small portable one.
Right.
Then I have a Remy, they're all portable. Okay.
Right.
The Remy 45-watt, I always say, and I want to focus on the small one because that's really the podiatry one, and I'll go over the advances. I only developed the 45. Yeah, podiatry can use it. It's great. You don't need 45 watts.
Right.
In podiatry, you don't need it. If you want it, you can budget it. Fine, but you don't need it. It's the Remy 30-watt dual.
Okay.
You need at least 2 watt. What's different is you now it used to have a surgical fiber. Now where you had to change everything. You had to take this is called a fiber optic cable. You had to unhook it. It's built right in. Okay. It actually, the Remy now, it's Android. So with these hand pieces, you can go from pain to the fungus to surgery in less than 10 seconds. You just change it.
Okay.
Is it more powerful? The Remy laser is not more powerful than it ever was in the first division. It's software changes. I can upgrade right through the internet like an iPhone. I can change programs for you. And that's why I did that, because we're in Europe, you don't need to be on site. You can tap right into their laser and make any adjustment you want right through the internet to serve. Which that's been a big change, a real big change. It's basically the same size, same quality, same service. Training is what's most
Right.
advances. My goal is to bring in new ideas that I learned from you. I learned, I knew it did well with wounds. But if I told you how many podiatrists, I said, use it right after the surgery, you get a better healing wound. You won't have, Dr. Barrett doesn't have to use antibiotics as much, because that they all admit, you ever get that redness after the surgery? It's a little aggravating. You put them on some antibiotics. Everybody that's doing surgery has had that happen.
Right.
And that is, thanks to you, that's been eliminated.
Well,
Or dramatically reduced. Nothing's ever eliminated. But I mean, they use it just on that little, the thing about I always try to take the best I can from everybody that I know and just keep adding to it. So,
right. So I've had the Remy for probably I'm gonna say about 5 years now, and I think
you were one of the first.
Really? Okay. All right.
Yeah.
So
that I can recall. I just remember talking to you on the phone. I was outside of a movie theater. They were putting on a show in France, and they were all speaking French around me. And it's raining. I had to walk out because I was talking to you. It was in the rain, and it's just amazing that you can talk to I didn't know if you knew I was there, but you can talk to somebody halfway around the world.
Right.
Through a little phone. I mean, look at our iPhones today.
I know.
Or your phone, the technology, and that's been my goal. I mean, the technology is just amazing. The software upgrades have been amazing. So, but your Remy can do exactly what the Remy today. It's always been multifunctional and portable.
All right.
And fortunately, affordable.
Yeah, no, very affordable. I think, I don't really know the market on lasers, but I can't imagine another laser out there with the versatility and the backup that you give and the support for, even close to the price.
Well, I'll tell you something I've added, it's been a while, and I still, if anybody ever brings it up, I always honor this, is that a laser has to stand on its own. The worst thing I want to have is somebody purchase a laser and they're not using it. It's sitting there collecting dust. Is I give everybody a 90-day return. You buy the laser. You don't want it. I don't want you to have something you're not happy with. Who wants to be? Life is much more important. And we've had 2 returns. One, a guy got divorced.
Right.
And he was going crazy. And I took it back from him. I said, you got to relax. He's all over the place. Then he rebuys it in a year. Then I had somebody during COVID lost his whole staff by himself.
Yeah.
I said, yeah. He didn't like my idea of doing house calls, but so I said, let's take it back. You regroup. You always got to regroup. There's always a solution as long as you're alive to regroup.
Well, I'm going to link everything to your company in the show notes. If people want to explore more, they can just go to thepotofinquiry.com, and I'll have all of the links there. And I'm sure that people will be very interested. And like you say, with this technology, it's not the end all be all, but it's certainly an integral step in where we all want to get as far as treating these patients with better technology equals better outcomes. And so I'm excited about that. I always love talking to you. I mean, we have to do this more often, and we'll do another one. We'll do it at wine o'clock and have wine chat. And I don't know. There's something about the Greeks developed the word symposium, right? For essentially wine drinking, right? Sim means to come together. Pos, P-O-S, is the Greek.
That I didn't know.
Yeah, pos is to drink, and eum is like a stadium, right? So symposium. So they would have symposium or symposia, and they would all drink a little bit of diluted wine. And they wanted to dilute it so that they got the benefit of being a little bit more relaxed, because a lot of these philosophical giants and academic thinkers would be a little bit buttoned up. They wouldn't want to necessarily show what they, or talk about what they had figured out, but yet they didn't want to get so inebriated that they spilled everything. So they would dilute the wine a little bit, but that's where the word symposium comes from. And
I'd be dangerous, I think, because I'm pretty loose to begin with.
Yeah, I know.
I do want to ask you one question.
Sure.
We talked about 007. You know where it came up, the code. I'm very willing to give to anybody watching this podcast that mentions, because I consider you 007. I'm giving them a special, there's a cart that we have. That's another, we have a cart. It locks right on. It's a beautiful cart, electronically, magnet hooks into it, full power. It actually cost me, I'm not exact, $1,000 to manufacture. I'm willing to give that cart to anybody that mentions 007.
Very cool. I'll put that in the show notes, David.
I appreciate it. I hope I was helpful.
Oh, you're very helpful. I can't thank you enough, and look forward to more chats. And I always learn from you. So thanks for coming on.
Vice versa. Take care now.
All right. Be well. I'll talk to you soon.
Bye-bye.
Right. Bye-bye.
I hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes found at our website, potofinquiry.com. If you think you might have tickled just a few neurons inside that cerebral cortex, please spread the word to your friends and colleagues and tell them that they need to get spelunking. Also, if you can take a minute to leave a review on your podcast provider of choice, and especially Apple Podcasts, that would greatly help the show and be so appreciated, provided it's positive. And if not, then just keep your pie hole shut and stay down in that cave. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.